So I couldn't agree with you more in the sentiment of needing to make sure that we're careful about being motivated just because something is able to be reimbursed. In a tongue-in-cheek way, I'll say I feel probably more strongly than you do on the dry eye side, and even some on the myopia management side. I mean, I live in CPTville, right? Or CPTville if you're from the South. And I'm at vacation in non-covered service city, but I don't live there.
Yeah.
And I'm not
Yeah.
moving there. And
Yep.
so to me, that's why when I invest in technology, I'm almost always, it has to have a CPT code because I feel like there's a certain level of, if CMS recognizes it as a test, it's reimbursable.
Well, welcome to the Chris Wolfe podcast. And as you can see or hear, I'm not Chris Wolfe. And we've got my friend Bradley, and neither is Bradley. So Bradley Grant's here with me today. Hey, what started this off was if you are a listener of us or you're a follower of iCode Education and Practice Performance Partners, you might get a bi-weekly newsletter from me called Optometry Simplified. And what I try to do in that newsletter is to share some links that I enjoy reading, some research articles that have helped my practice. And I also take a deep dive into some things that I've been thinking about. And one specific week about, 2-3 weeks ago, I think, Bradley, when you and Chris had the podcast released, right? So 2-3 weeks ago or so?
Yeah.
I think so, something like that.
Yeah.
So I was out for my morning run, and usually, I'm a Chris Wolfe podcast junkie. So most times on my Monday morning run, I throw in the ear pods, or the AirPods, and listen to some podcasts, and maybe his interview comes up. And I was listening to Bradley and Chris talk about the red eval. And there's some things in there that I liked, and then some things that I disagreed with. And I just figured, you know what, why not stir the pot a little bit and write up my deep dive for that week on why I have not chosen to, integrate or buy into ERG yet for my practice. Now, one caveat that I have to make in this is that I've been in 2 practices in the past that have had ERG from the old, it's okay if we say names here, from the old diopsis model.
Right.
I used diopsis ERG for at a glaucoma referral clinic. I worked there for about 2-3 years, seen a lot of glaucoma and neuro patients, macular degeneration, diabetes patients. And then about 3 years ago, when I bought our second location, that location also has a diopsis, and I still have the diopsis in there. It sits there, it's gathering a lot of dust. So that would probably be coloring some of my experiences of the ERG, but that's where my disclaimer is in terms of some of my experiences. So yeah. I think
can I say my point of view?
You can definitely go for it. Please do go for it. Yeah.
So for those of you the 3 of you that follow me on LinkedIn, you know that. I was at the Vision Source Exchange, and if you're ever at an exchange or a conference and you're speaking at the same conference that Kyle or Chris are speaking at, there's a very distinct difference between my talks and their talks. And theirs are standing room only, get there early. Mine are filled with plenty of empty seats. You don't even have to be on time, right? So that's the backdrop of where we are.
I don't think so. Yeah.
And then I wake up in the morning and I see that I have a notification on LinkedIn, which happens once every 8 months. And it's from Kyle saying how much he dislikes ERG, and I thought, gosh, why now? So that's
why now?
Yeah, that's my history of why I'm here.
That's your history for sure.
Yeah.
Well, I thought it'd be best, and we kind of talked about it a few weeks ago at the Vision Source Exchange, and we talked with some of the reps with Red Eval, with LKC, and we thought it'd be best. Hey, let's actually have a discussion on this. Let's have
Absolutely.
a little bit of maybe a back and forth debate, because at the end of the day, what I know, Bradley, what you're after, and what I'm after as well, is first and foremost, we want to do what's best for our patients, right? And we have to believe that what we're deciding for our patients, and it's not like we're taking that lightly at all. You don't take that lightly. I don't take that lightly, right?
Right.
And clearly we've arrived at different positions for making that decision for our patients. And I think that's okay. I think that's just part of, like, a lot of things that I write about in the newsletter and my column, the Journal of Medical Optometry, is about following the science. It's about evidence-based medicine. And it's the reality that evidence-based medicine, we always think it's like this clear cut, like there's one, it's black and white. The evidence points specifically in one clear direction. And the reality is it really doesn't. And that's the reality of science. Yeah. That's the reality of understanding and exploring and discovering new things, is that we constantly have to decide, like, what amount of certainty and what amount of uncertainty are we willing to make decisions with, right? And what tools do we need in order to reduce that uncertainty for our patients? So I think that's a great way to kind of kick it off. But I think one way we could do this is just going through, and I don't know if we have you have a rebuttal or a point by point, but I think it might be best. I'll go through my newsletter, unless you have something to say to that.
Yeah, no, I would completely agree. And as we talk about it, and anyone who's maybe ever heard me talking on ERG, I'll use a lot of analogy to glaucoma, and I think there's some great parallels to what you mentioned about kind of living on the edge of uncertainty and just going with the best information that we have. In some of our really landmark glaucoma studies that we all practice based on, and if we kind of dive into, okay, why are we motivated to treat in the way that we do in other conditions? I think that opens the doors to conversations about newer technology and its clinical relevance.
Absolutely.
Hey, iCode Media listeners, want to know how AI is really going to impact your practice? Join us Tuesday, June 24th in Minneapolis, right before the AOA, for the kickoff of the Gateway Tour. It's a full day, live workshop where your whole team learns insights and team building exercises together. We'll demystify AI, explore how data and tech are transforming optometry, and dig into real strategies to optimize performance clinically, operationally, and culturally. You'll experience a live AI workshop, learn what's working in other industries, and leave with a roadmap to lead confidently into the future. Reserve your team's seat now at gatewayculture.com. The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education, for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com. Hello, dedicated optometrists. Are you looking for a way to support your patient's vision and overall eye health? Let me introduce you to Vision Edge Pro, a visual performance supplement that stands out in our profession. Vision Edge Pro contains a balanced blend of mesozeaxanthine, lutein, and zeaxanthine in a 10-10-2 ratio. This combination has been scientifically shown to increase macular pigment density, which enhances visual performance, including contrast sensitivity and vision in glare situations. Additionally, Vision Edge Pro provides 300 milligrams of DHA and EPA, fulfilling the daily requirements for omega-3s as recognized by the leading health organizations. This ensures your patients receive the essential nutrients their eyes need for optimal health. Whether it's for everyday screen use, night driving, or enjoying the outdoors, Vision Edge Pro supports your patients in seeing their best. Recommend Vision Edge Pro for your patients today and help them achieve clearer, healthier vision. Contact your local MacuHealth representative for more details. Vision Edge Pro, because your patients deserve the best in eye health. Go to MacuHealth.com and use the coupon code podcast2024 at checkout for special discounts.
Well, let's go through here. I basically said, why have I chosen to hold off? And also, just as a point to make here, I did put yet in my title. I'll just read my title here. So I just want you all to know that if I am up speaking sometime and I talk about a patient that I'm using red eval with, don't be coming back at me, saying, "Oh, he's sold out" or something like that.
Flag. Yeah.
I'm it's this is where I'm at right now. So why have not adopted ERG yet? So anyhow, so the first point that I made is why have I chosen to hold off is one is just like when we think about surrogate endpoints, don't automatically translate to better patient outcomes. And when you look at like when I think of the DR score and like the photopic negative response curve, like those are valuable pieces of information, but we always have to put them in the context of the overall general idea of like, what are they really telling us? Are they, for the most part, the DR score is what we would call a surrogate endpoint, similar to like A1C. A1C is a marker for diabetic
risk.
Change,
right.
For risk. Yeah. Exactly. And so, however you think about that, you kind of have to realize like, hey, if you treat enough diabetic patients in your practice, you realize that even though the DCCR said that we need to have everybody below 7.0 to reduce the risk of retinopathy, you still get retinopathy in patients with 6.7, right?
Mm-hmm.
And you can also have patients, time. And you can also have patients with 8 to 9 or more A1C, and they don't have retinopathy, right? And so it's a proxy. It's a helpful measurement, but it doesn't 100% correspond to that. So that was one of my reasons for questioning some of the results for ERG. So I don't know if you have anything on that, Bradley, but
so just in terms of the definition of surrogate endpoint, I think that when I look at it, I think we need to make a distinction between endpoints based on treatment. So you had sent an article about an oncology medication, right? So a surrogate endpoint might be that a tumor is shrinking, but does that improve survivability rates, right? Which is a great question because you might look at it and say, well, it's shrinking the tumor, it's obviously helping, but maybe not. But I think there's a difference between surrogate endpoints as they relate to treatment and surrogate endpoints as they relate to testing that's helping us assess risk to begin with, because there's so much more blue sky when we talk about just assessing risk. And so I would say that in an instrument like the ERG, when the point is to assess risk, surrogate endpoints are not necessarily a bad thing, even though it might be truly what it is. Now, to maybe dive a little bit further into the study that I would base my confidence in the test on, or where I would say that it's a piece of information that I want to have, right? So the Bruegel study, which is kind of I would say the hallmark optometry-based study. I mean, the ERG does have over 200, peer-reviewed studies that are published, but the one that I would say is the optometry-based study would be the Bruegel study that took patients and divided them into 4 different groups, right? And so it utilized the DR score as segmenting those groups. So in the first group, you had individuals, everyone had diabetic retinopathy of some form. So in the first group, you had less than severe diabetic retinopathy and a DR score of less than 23.5, right? And it looked at how long, or what was the percentage of individuals that would progress to needing retinal care, right? So macular edema, proliferative changes, and PRP injections, whatever you have, it would be retinal care. So in that first group,
so you said that first group was less than retinopathy or low retinopathy, right?
Low retinopathy.
Okay.
and less than 23.5 DR score. So think about it like if you segment it like structure and function, right? This group has no structure, no function problems, right? And the likelihood of those individuals progressing is 6%, right? So very low, right? And so in that case, does it give us significant clinical information standalone, right? Not necessarily. Next group would be just structure, not function, right? So does have severe diabetic retinopathy, but DR score is good. So functional assessment, fine. Anatomical changes, bad. The next group, and in that subset, 18% progressed to needing retinal care within 3 years.
Okay, so basically we're 1 out of 5, 1 out of 6. Yeah.
Right. Next group is just the opposite. It's structure fine, function bad, right? So DR
So this
score,
would probably be, sorry to interrupt, this would probably be a group that would be most impactful.
benefited. Yes, yeah, because you have, so this is be an individual would have microaneurysms only, right? So you've got mild non-proliferative changes, but you're showing significant stress on the functional side. So in that group, pretty similar to its reverse, 20%. So still in that 1 out of 5. And then the last group has structure and function together as a problem. So a DR score greater than 23.5 and severe non-proliferative changes, right? In that subset, 68% progresses. So I think the argument on the surrogate endpoint is you're a good clinician, right? You say, I look in the back of somebody's eye, I see severe non-proliferative changes, right? I see hemes in all quadrants, I see venous beading, I see potential IRMA. I don't need another test to tell me that they're at high risk for progressing to proliferative changes. I think that's a logical assumption. So I don't even place that much confidence in that last group, even though the number's most significant. I place the confidence in the difference between structure alone and functional alone compared to structure and function combined. Because if you look at 20%, roughly 1 out of 5 compared to, 2 out of 3, I mean, there's a big difference whenever you include functional and structural together. And so I think that we're potentially missing a big piece if we're only looking at structure. And currently, all of our diabetic grading scales are based on anatomy only, right? And so I would think we're missing a piece.
So the ultimate would be, honestly, if you were to look at that subset of patients, because I would agree with you, if you're looking at that data, you're going to look at those patients are going to be the ones that fit that, both structure and function. That's a no-brainer, right? You're seeing those are the patients that, clearly you're going to be helping out. You're going to, the likelihood of you improving their outcomes, their visual outcomes at the end of their life is going to be high, right? Whereas at the end of the day, like I think I forget what point, but basically like, can we really prove, and this is where you have to make that leap a little bit. And it kind of goes back to evidence-based medicine of, do you just, can you deal with the uncertainty or not? How much uncertainty can you deal with and how much can you educate your patient? But with those patients that you potentially, have that gap with, are they going to have worse outcomes in the end if you don't, if you're just seeing structure only? So that would be the part that like, and maybe I shouldn't need a study like that. Maybe I'm being too cynical or wanting too much evidence to really like hang my hat on of saying, hey, yes, it's predictive. And I agree that, yes, that sounds like a really nice confidence interval. And I think the confidence interval was like 3 or 4, something like that, in terms of where we were in terms of its predictive ability for those that need some sort of intervention later on. But at the end of the day, like to have the ultimate sort of evidence is to say that those patients actually did fare better, the ones that had the ready valve done on them, and it showed that their functioning was down, right? Versus the patients that didn't have Ready-Val on them, and it showed that their functioning, we didn't know that, and they had worse outcomes. So that's
Yeah.
where I like kind of get caught up. Is like, okay, at the end of the day, am I really going to do anything better for my patient? Is there really going to be better outcomes visually for them?
Yeah, and I think the difference in call to action, because I certainly agree with what you're saying, is you're wanting to make sure that you catch that 1 out of 5, right? But
Yeah.
is there a study that shows that if you catch that 1 out of 5 and you project out 10 years from that point, who has better functional vision, right? In that sense, you're just kind of trusting, the predictive ability of the test, and so and there's other confounding factors too. So I guess I understand that, but I think that where it changes my course of action would be in conversations and in follow-up care. And again, we can make the same argument, right? Does increasing your follow-up care actually result in better patient outcomes? I guess so difficult to be able to necessarily prove that. I think that anything that you can do to better educate your patients, you're going to increase compliance, but again, I think in some ways you just have to say, I'm trying to do right by my patient as best you can, gather as much information to help them help themselves, and give them a realistic outlook of what their risk factor is, and then catch those that have dot hemes, but obviously have a lot more going on if there's functional stress involved.
Yeah. Do you find, Bradley, that having that, and obviously I think I know the answer to that, but do you find that, so you see that patient, you say, hey, this is the value of this score. This is, telling us that your eye is relatively more sick than it looks like. That's probably how I would describe it, right? And what that tells us is that we need to watch you sooner than we would typically watch you because your eye is sick. It's just we can't really structurally see it yet. And also that means that you need to be better controlled with your blood sugar. We're talking specifically about diabetes right now, and we could definitely go into AMD and glaucoma care as well eventually here. But do you find that is a pretty good way to have that conversation, and maybe do you just share with how do you describe that to patients? How do you articulate that?
So I set the test up by saying this is measuring the speed and the strength of the response that the eye generates and then sends to the brain. And I say that, the speed and the strength are based on how healthy are the cells and how many cells are there. And if the signal is slowing down, it means that there's some stress there. If it's weaker, that means that we've lost cells. And so most of the time I can even, there's going to be lower amplitude that's influenced that bad DR score. So we can say, look, there's a lower volume of actual functional tissue. And I think that there's something that resonates well there when you talk about nervous tissue that's not coming back, right? Because patients will ask, well, can the bleeding get better? Yeah, it can. But when you start talking in terms of this is gone and good chance not coming back, I think there's a little bit more power there. Now, can I put numbers to it for you? No. And so I think that we can always keep coming back to the same thing of where's the hard evidence that it improves outcomes, and I think that's just based on gut feeling and trust, but I do think that it improves the conversations more so than before we had the test, and it helps us to identify those that are at greater risk based on what we might see just anatomically.
Awesome. Next point was, do you feel like there is a risk, I'm just going to go down to the points here. One of my points, number 5, is risk of overtreatment, overmonitoring, and patient anxiety. Do you find that is that something that, is that, unfounded in terms of my concern about that? I say introducing a test that shows abnormalities that don't yet require intervention can cause unnecessary patient anxiety, increase follow-up burden, and even create pressure to treat or refer prematurely. See that at all?
What's that?
Yeah. Do you see that at all? I mean, is that something that you experience or?
Yeah, I think all kind of depends on how you use it. I mean, if you're overusing the test, then I think that there's an argument for that. I think the question behind that question would be does the test really show what it's what it says it's going to, right? Because
Mm,
if a test shows abnormal function, then it's not over-testing. It's not showing useless information. So if it's correct and it's
very
abnormal,
true.
then it's significant. If it's not showing what it says it's showing, then we should be talking about a whole completely different thing. But
Yep.
if the test is normal, then I think that also gives us a positive talking point, which is sometimes just as important for patients as well, right? Not necessarily
Sure.
always that you're headed down the wrong path, but look, keep up the good work. You've been diabetic for 15 years. The numbers would show that you have a 60% chance of having some form of retinopathy. Your retina looks clear and your DR score's 18. Keep up the good work. And so,
Yes.
does that change my clinical decision making? No, but is it,
Right.
good practice management? I would argue it helps. I mean,
Yeah, it's a
could you
great point.
overuse it? Yes. But if it's telling us what we think it's supposed to be telling us, abnormal should be a red flag and should be paid attention to.
I think it goes back to those that are comfortable with managing chronic disease in their practice. And Chris and I talk a lot about this in our comprehensive optometry simplified program, is that one of the things you have to get comfortable with and that we aren't necessarily trained that well on, because the way our training goes, we like to just, patient comes in with a problem, we fix the problem, and then they come back in a year and we fix a problem and they come back, right? And that's different. That feeling of interaction with the patient is a whole lot different than managing a chronic illness that you're hoping doesn't change, right?
Mm-hmm.
That's different than the 2 diopter myope going to 3 and you're clearing their vision and they're happy and then you're the hero and they see better, right?
Right.
Whereas in a lot of AMD care, in a lot of glaucoma care, diabetes, like the good thing is when the patient is stable
Mm-hmm.
and you maintain that, whatever it is, that 3 to 6 month follow-up period, and you're having that discussion. And the reality is like, I've got a lot of glaucoma patients, a lot of AMD patients, and I'm having pretty much the same discussion. Like, I'm sure
Right.
you are
Yeah.
too,
And that's,
over and over and over again. Hey,
yeah.
guess what? Your fields look great. Your pressures are great. There's no changes structurally on your OCT today. So you're doing everything really well. We'll do this again in 3 months, right?
Yeah. Yeah. And I
And
even
you got
say
to
that
get
to the
really comfortable with
patients.
that.
You
Yeah.
say, look, if we have the exact same conversation 2 to 3 times a year, I know that seems really boring, but it's actually fantastic news for you.
It's a good thing. Yeah.
Yeah. Yeah.
And it's not over treatment at all. So yeah, that's a great point. So what do you think about, I made a point here, and I know this is a kind of a sticky subject in terms of financial pressures. And I'm not
Mm-hmm.
trying to call anybody out or anything like that, but sometimes I do. I'll be quite honest with you. The first time when, thermal pulsation came out, I won't say the name or anything like that. Um, I think that there's value in it. And when you look at the studies for thermal pulsation in dry eye and meibomian gland expression, it's helpful for some patients. I don't honestly think it's helpful for every patient. Even for the patients that are perfectly like obstructive meibomian gland disease, the payoff sometimes is like, meh,
Right.
but I think we tend to push it a lot. I'll be honest with you, because it can be it was $1,000 or $1,500 at the start, so it was all the rage at first because look at the revenue that was pulling in. And I wonder sometimes, I treat a lot of dry eye. We do those things in our practice. I treat a lot of myopia management. We do those things in the practice. We prescribe all the lenses possible, everything we do. But I wonder sometimes if the buzz around new products like that are a little bit too high because of the potential for reimbursement.
Yeah.
And I'm not, I don't know if you have any response to that, but that was my point with this as
Yeah.
well. So what if, if it was a third the price, like OCT of the macula is right now, would it have the adoption that everything else has? Maybe it would.
Right. Right. So I couldn't agree with you more in the sentiment of needing to make sure that we're careful about being motivated just because something is, able to be reimbursed. in a tongue-in-cheek way, I'll say I feel probably more strongly than you do on the dry eye side, and even some on the myopia management side. I mean, I live in CPTville, right? Or CPTville if you're from the South. And I might vacation in non-covered service city, but I don't live there.
Yeah.
And I'm not moving there. And so to me, that's why when I invest in technology, I'm almost always, it has to have a CPT code, because I feel like there's a certain level of, if CMS recognizes it as a test that's reimbursable, there's some solid nature to it. There's enough research that says this is a necessary test. I mean, you can still overbill if it's a CPT code. There's no argument about that. But I think we just have to balance that. And at the end of the day, we all have to wrestle with our own, conscience on that. Am I doing this for the right reasons? Am I doing this to take care of my patients? For me, right, if the reimbursement was lower, I'm confident in the value of the test. I think it helps to elevate our clinic. I can't completely separate myself, and you can't, I know you would agree with this. You can't completely separate it, because we're business owners, we're practice owners. Like if we were 100% altruistic in that way, we'd work for the VA or the schools or something.
Right.
But I also think that we have to look at the alternative if we don't own those decisions, right? If we don't own those decisions, then the patient's likely in the hands of going to seek care at a hospital system or a retail setting or a private equity, right? I think as private practice optometrists, we need to make sure that we're owning those decisions respectfully. Right. If we're in charge of doing that, we need to make sure we're respectful for the patient in that way. So
I love that.
I
agree.
Yeah.
What do you think about the point? And this is one of the last things we'll kind of bring up. What do you think about the point of like being careful, or not careful, but it's something that, say, you're having the patient back. You've got one of those, you've got structures, maybe mild to moderate retinopathy. And obviously we're still talking in the diabetes realm. Because I think that's kind of where probably the most used utility for the Ready Valley is right now, right? There's definitely macular degeneration. There's a lot of value in macular degeneration. There's a lot of value in glaucoma as well. But in terms of the DR score and those things, diabetes is kind of the realm that we're kind of thinking of. So those patients that may be mild to moderate NPDR and high DR, at the end of the day, even if we follow them up, right, we aren't going to, or maybe they're at the point where they're not quite intervention yet, but the surgeon that's going to do the intervention isn't cognizant or doesn't recognize the value of ERG. So that kind of puts us in a position where, like, okay, we have this value, and maybe there are, like, you can inform me, I'd love to hear more. Maybe this is making its headway into the retinal space in some practices.
So I would say that, and you and I have talked about my mode of practice is that we're, OD, MD together, not just as providers, but owners as well. And our MDs that do, retinal treatment for diabetic retinopathy really have let primary care own it in terms of that technology. I think that, not that it doesn't have value, but I think that when you look at like the Burgell study that we were talking about, the end point for risk prediction is ending up in the chair of, the referral. And so, I think about it like, my wife and I both grew up in towns by a river, right? Not in vans down by the river, but in towns by rivers. And every now and again, the river floods, right? And so all hands on deck for sandbagging to make sure it doesn't flood. Once the water breaches the levee, now we got a whole different set of problems. It doesn't necessarily devalue the importance of trying to sandbag. And in that case, I think that's where we land in terms of primary care and optometry, is that I would say that my personal experience, our MD colleagues in my practice don't use the test in the same way that we do in primary care, but we're trying to put up enough roadblocks before they have to see them. And so I think that's, in the diabetic space, maybe the most valuable utilization of the test. Now, glaucoma, I would say, is a little bit different story in terms of the PHNR, but from a diabetic risk prediction DR score. We're trying to keep them out of that chair. Once they're in the chair, I think that, then we go to the, non-surrogate endpoints of reducing macular edema, reducing, size of neovascular nets and things like that. So I think it just changes the game. Wait a second. No, I won't say it. Yeah.
One game changer. It's a game changer, right?
I was trying to think
is it a unicorn, Bradley? Is it a unicorn and a game changer? That's the best for me.
Thinking of a word rhymes with name changer, and I wanted you to have to say it. Yeah.
CooperVision and the AOA have joined forces in a groundbreaking initiative to transform how optometrists treat children with myopia. The Myopia Collective aims to unite our profession and its allies to challenge the status quo and elevate the standard of care for children with myopia. Everyone is invited to become a member of the collective. By joining, you pledge to act in slowing childhood myopia progression. Membership includes regular updates and information about the collective's efforts, access to educational opportunities and resources, and insights from the ambassador optometrists who advocate for community policy and changes supporting the collective's mission. Click the link in the show notes to join the collective today.
Yeah. So just so you know, as an aside, I'm allergic to the phrase game changer and unicorn when it comes to marketing. And there might be, tools and new technologies and treatments out there that are game changers. And I'm hoping there are more of those, but I cringe when I hear it, and that's my own problem, I know. Hey, one quick aside, you mentioned the van down by the river. Just for those that are not in their early to mid 40s like you and I are, that is from an SNL skit of a guy named Chris Farley that Bradley and I grew up watching. So go back and find that on YouTube. It's pretty funny. So
I'm just if you didn't catch that reference, then
hey,
I don't know what to say.
You never know. It's some of the new grads, they're probably like, mid 20s, late 20s. They probably may not have seen a Chris Farley skit before.
Yeah, that's true.
So, let's make that pivot to glaucoma. Now, in terms of the glaucoma realm, like we included some slides on the photopic negative response curve. I think I'm saying that correctly. Mm-hmm. In our glaucoma protocol when we did that a couple of years ago for the Vision Source glaucoma protocol. And at that time, and you can correct me if I'm wrong, because I'll just allow you to kind of teach us a little bit more about how you can use it in the diagnosis of glaucoma, ocular hypertension, and those things. But what I recall is the part that I found that would be very valuable for a clinician is, when you think about what it's measuring, it's basically measuring a sick ganglion cell, right? The ganglion cell is sick before it's dead. It's going to be sick before it's dead and thinned, right, or atrophied. And so, and you can correct me if that understanding is wrong, but I always found that'd be a helpful thing, because there are a lot of patients where you feel like, man, maybe they've got perfect nerves, but they've got high pressures and 27 OU pressures, and they've got great nerves, and you're just thinking, should I really treat these people or not? And we do have things like corneal hysteresis that sometimes tells us it's kind of like a functional measure. It's kind of fallen out of favor a little bit. We still use it at one of our locations. Or maybe you've got a patient that, maybe they're mild. They've got no visual field defects, but they've got a little RNFL change, and you've got a decreased amplitude of the PHNR curve, and then that's going to help in decision making. So explain kind of how what's the value of that in glaucoma care?
So I'll give just a brief example of a case, and then I'm going to dive a little bit deeper into kind of what we had talked about earlier in terms of landmark studies, and like you just said, I wish I had more information, right? So we use it as sometimes that extra kind of tip the scales a little bit. I have a patient that, and if you're free, June 2nd, which I guess is next Tuesday, Dr. Nate Leiheiser and I are doing a ReadyVal workshop, and I'm going to be presenting a case where it's your classic, ocular hypertensive, elevated pressures, but she also has significant dry. So we've tried her on different medications in the past, and it's always I mean, it's like the patient that you give a sample of Vyzulta to, and it's not like a week later they say it's irritating. It's like they call you the next day and say my eyes. I mean, everything. She was lit her up. And
Hmm.
sometimes I'm wondering if she's even serious about it. It's that dramatic. But
Hmm.
she is elevated pressures, has just a little bit of wedge defect superior on the nerve. Pre-parametric, her visual field is perfectly fine, and she is in her late 40s. So we're looking out at a landscape of many decades where we're trying to protect her optic nerve and her vision. And we had started doing the PH&R test on her, and we were able to demonstrate over a 6-month interval an increase in the latency. So again, as you're talking about, sickness of a ganglion layer, for those who maybe think about
Yep.
it like fundus autofluorescence, right? Like
Yeah.
it's on the way, right? On the way to
Hmm.
dying, not dead and gone. And so that was the tipping point for her, actually. For us, I mean, we've already said, we think we need to treat you, so we've tried different treatments, but she wouldn't use drops. She was opposed to SLT, but when we were able to demonstrate to her, look, your function is going down, even though we can't see it yet on the visual field. That was the tipping point for her to say, yeah, let's do this. And we were able to get her in for SLT, and she's doing great. So it was another clinical justification for us to be able to say, we know that function is changing. We don't need to wait until we have a nasal step, right? And it was
Hmm.
justification for her to say, okay, I'm ready to do a procedure more so than drops or watch it. And so in those cases on the fence, I think is where it's most valuable.
Yeah.
Yeah.
Yeah. Where you're questioning, I think the cases too, and maybe I'm wrong here too, like the cases where I think there's probably more often cases like what you just talked about, right?
Hmm.
But then there are also cases where, I have patients that are just lousy field test takers.
Yeah.
I have
Yeah.
patients that, one of the things I've wanted OCTA to be, and it really hasn't become that yet for glaucoma, is for those high myopes, right? Those, high myopes where that nerve, like
The red
you have
disease.
no
Yeah.
idea how do you grade that nerve? There's
Yeah.
just no way.
Yeah.
And then the OCT just looks like a mess, and then their field is kind of diffuse. There's nothing specific, but really, like, what do we look at there?
Yeah.
So I can see some definite value there.
Do you have patients, and I think I probably know the answer to this, but do you have patients in your practice that would be most accurately classified as ocular hypertensive, no field defects, but you're still treating, right?
Yep.
Yeah.
Yep.
And the reason why I do that and the reason why you do that is a lot of it out of the OAT study, right? The ocular hypertension
Right.
study, right? Because
Hmm.
because the banner out of that study is 50% reduction, right, in terms
Right.
of treated versus not treated. But if we dive
Right.
into the numbers, and you probably know where I'm going on this,
Hmm.
the numbers are 9.5% got worse in the non-treatment group, 4.4% got worse in the treated group. So we're really only talking a difference of 5% or 1 out of
Right.
20 in terms of treated versus not treated. So for every 20
Yep.
patients that you and I treat in our practice that are ocular hypertensive,
Hmm.
18,
We're gonna
18
help
of
one.
those, 18 of those
Hmm.
didn't matter. One of
Right.
those getting worse no matter what. And we helped one.
Yep.
And we don't
Yep.
know, and that's a landmark study. We base our
Right.
clinical practice off of it. And
Yes.
so the idea that gaining new information, can't be valuable. You absolutely did not say that. I'm not trying, but
No.
the idea that there's many times when, man, just one extra piece of information would help us to determine who's that one and who are the other 18 that actually I could just watch them, right? I mean, their pressure's 26, everything else is fine. I could just watch them. So I think that's where it comes in most valuable to me is on those, classic ocular hypertension studies.
I knew that when they paired me with you, that this wasn't going to go well for me because of, my heartstrings with Game Changer and also with number needed to treat. So one of the things I try to really hit hard is like, hey, we need to know the number needed to treat for all the
Yeah.
things that we prescribe, right? And
Yeah.
you just nailed it. Yep, the number needed to
Yeah.
treat for ocular hypertensive patients is actually 20. We need to treat 20 patients to help just one.
Yeah.
And we feel, and that seems like a lot, but the reality is, when you look at the studies for statins to reduce the risk of a, cardiac event for low risk patients, it's like 150 or something like that. I forget,
Yeah.
150 patients for just that one. So for the new, if you read the newsletter, another shameless plug, if you read the newsletter from yesterday, you'll see that closely is you need to treat about 4 to 5 patients to get one patient improved, monocular improvement to functional vision, near vision.
Mm-hmm.
Whereas Vuity, kind of the corresponding or comparative type of drug, was about 1 out of 4 or 5 to binocular improvement. So, but those are super helpful ways to look at that number needed to treat.
Yeah. Yeah.
Absolutely.
And said, you and I both know those things. And I want to make sure I give credit to the individual who laid that out for me many, many years ago, Dr. Jeremy Anderson in Manchester, Tennessee, most brilliant, optometrist I've ever spoken with. You and I both know that 18 out of 20 are, somewhat of a waste of time, right?
Yeah.
But if I was pressed for 26, I'd still take drops myself, right? And so
or an SLT or something,
right, yeah. So we just have to go with our gut of, we don't want to be okay with the one that gets worse that we could have helped. So, we make our best judgment with what we have.
Absolutely. Well, in order to not labor on and on about ERG, we've kind of gone back and forth on several different points. I think we've done a good job here, back and forth. I don't know if I've convinced you of my points or you've convinced me, but like I said at the beginning, it's a fantastic way to just discuss. And I feel like we kind of need more of this in the profession of kind of competing sides of why we do what we do. And I want, again, going back to evidence-based medicine, the idea is we're all kind of, as clinicians for our patients, we are in the position to discern and decide what's best for our patients using the filter of evidence-based medicine. So if I can end the discussion tonight just with a little bit of a quick review of what that is. When we think about evidence-based medicine, the way that we filter that information is, number one, there's basically three. You can kind of visualize it as like three rings or three circles that kind of join in the middle. And one of them is going to be your research evidence. That's going to be your randomized controlled trials, that really high level evidence. The next one is going to be expertise or experience or opinions of the experts. And then the other one is going to be your patient preferences. And you basically, when you decide to bring something into your office, when you decide to do something for your patient, when you decide to intervene in some way, you should be using those three filters to figure out, hey, what's the next best thing for my patient? And so when research, Bradley and I look at the same research and we're reading the same research. When the research is showing us like, hey, it's given us some certainty, but not perfect clarity, like we just discussed in the Oates trial, well, then we have to use the next filter of our experience and our opinion and kind of our speculation and what we've seen and heard and known about the disease. And then we got to filter that through what does the patient really need and want right now. And that's why you can have such diverse opinions. And does that mean one opinion is right or one is wrong? I mean, you can debate that, and that's the reason we do that. We have those debates. So I think it's valuable to understand the context of this, and I hope we can have more discussions like this in the future. So, any parting words there, Bradley?
No, I think I mean the way you described it is absolutely perfect, and like I said, it just a pleasure to get to discuss it with you. I mean, highly value your opinion, your thought process, all the content that you put out. And again, last thing tongue in cheek is that I just respect you too much to see you're on the wrong side of progress. So, that's why I felt.
That's good. Well said there. I'm still in we talked before we got on if anybody's ever seen the Seth Godin, the dip, which is just this curve of the early adopters, and then there's a dip to stagnation of the people. I'm definitely not an early adopter, so I'll tell you that straight up. So maybe I'm an adopter later on in the curve. I let everybody else figure it out, and then I'll join in on the fun.
You're a longitudinal study guy. That's fine.
That's right. Yeah, just give me the RCT. Absolutely. I need a 10-year RCT, and then I'll be fine. So
yeah.
All right. Well, I appreciate your time here tonight, Bradley, and to our listeners, thanks for listening, and feel free to reach out. Find us both on LinkedIn, ask questions, and I hope you got some value out of the discussion tonight. So thank you.
Yeah. All right. Thanks.